Hello, I'm Dr. Leong. Today I'm going to talk about managing excessive cough and phlegm. In this presentation, you will learn about the cough reflex and mucus production, the causes of excessive cough and phlegm, and learn how to cough gently and bring out the phlegm. Disclaimer: the material used for this presentation is for educational purposes only. Please consult your doctor if you have any medical problem. This presentation is brought to you by the Perak Chest Society or Persatuan Kesihatan Dada Perak, Lahad Road YMCA, and Leong Chest Clinic. Cough can be acute, subacute, or chronic. Acute cough are less than 3 weeks old, and subacute coughs between 3 to 8 weeks, and chronic coughs more than 8 weeks. Cough is actually a protective mechanism. It helps expel from the lung gas, noxious gases, fluid, dust, and microbes, bacteria or viruses. The cough can be productive or non-productive. A non-productive cough is also known as a dry cough. Cough can be caused by infection, whether bacterial or viral. It can be by choking, like accidental swallowing of fluid into the airways during eating, smoking, air pollution, gastroesophageal reflux disease, post-nasal drip, like in rhinosinusitis or allergic rhinitis, heart failure due to fluid in the lungs, ACE inhibitor, medicine used for treatment of hypertension, and lung diseases like asthma, chronic bronchitis, lung tumors, interstitial lung disease, and many others. The cough mechanism has 3 phases. First of all is inhalation, a deep breath, followed by forced exhalation against a closed glottis. There's a buildup of air in the chest, and a sudden release of air following the opening of the glottis, causing an explosive expulsion of air, which is the cough. Cough is a reflex. There are receptors in the upper respiratory tract, like in the nose, sinuses, and pharynx. These impulses from the receptors are sent to the medullary cough center by the trigeminal nerve and the glossopharyngeal nerve. They are also found in the diaphragm and in the ear. Like in the ear, when we clean our ears, it can elicit a cough. They are also found in the lower respiratory tract, like the trachea and the bronchi, and the esophagus, and that's why you have gastroesophageal reflux causing cough, and also in the pleura. From the medullary cough center, the muscles activated will include the intercostal muscles and the diaphragm. They are responsible for contracting and also causing the air to be forced out from the lungs. The vagus serves the larynx, which is important for the control of the glottis, closing and opening of the glottis as when the cough occurs. In the airway lining, there are mechanoreceptors and chemosensors. The rapidly adapting airway mechanoreceptors and the slowly adapting airway mechanoreceptors send signals to the medullary cough center. So are the C fibers and the A delta fibers. They are sent to the medullary center via the trigeminal nerve, the glossopharyngeal nerve, and the vagus nerve. The cough center is located in the hindbrain, in the medulla and pons, mainly in the medulla. The relay center for the afferent and efferent nerves is the nucleus tractus solitarius, also known as the NTS. The afferent nerve impulses are sent to the chest wall muscles via the intercostal nerves. These are responsible for breathing and also the cough. The phrenic nerve supplies the diaphragm, whereas the vagus nerve, while the recurrent laryngeal nerve opens or closes the glottis. Mucus is normally produced in the airways. It is protective. It forms a film to trap the dust, bacteria and viruses, and also noxious gases that lands on the airway. The mucus contains water, mucin, glycoprotein, immunoglobulins, lipids, DNA, etc. Here you have a picture showing the upper respiratory tract and the lower respiratory tract. The upper respiratory tract is lined by an epithelium containing submucous glands. Here you also see the ciliated columnar epithelial cells, the basal cells, and the goblet cells. The goblet cells and the submucous glands produce mucus, which forms a layer over the cilia to trap dust particles, bacteria and viruses. Mucociliary clearance. This is a picture showing a ciliated columnar epithelial cell. The cilia beats 15 cycles every second and propels the mucus on it in one direction, that is towards the upper airway to be swallowed. And the mucus moves about 10 millimeters every minute. Mucus can be taken as normal, whereas phlegm and sputum is to be taken as abnormal. In describing the abnormal phlegm or sputum, one has to note the color, whether it is clear, light or dark yellow or green, brown, gray or red, which signifies blood in the sputum. One also has to note the amount, whether the production of phlegm and sputum is excessive or more than the usual amount in some diseases like bronchiectasis. And also one describes the viscosity of the phlegm or sputum, whether it is sticky, thick or fluid. And the time of production, whether the phlegm or sputum is produced a whole day or during certain time like during sleep. And whether the phlegm or sputum will be expectorated when lying in a special position. There are several causes of persistent cough. Persistent cough is taken to be cough of more than 8 weeks duration. And the common causes of persistent cough include chronic bronchitis, infection like in pulmonary tuberculosis, and bronchiectasis. Today we shall take the disease bronchiectasis to illustrate a case of chronic cough and persistent phlegm production. The problem of bronchiectasis include dilated airway lumen, thickened airway wall, abnormal mucus clearance, increased mucus production, and recurrent bacterial infection. Here is a diagram showing bronchiectatic airway, where it is dilated with thickened airway wall and collection of excessive phlegm or sputum. There is also the absence of cilia, whereas in a normal airway it is not dilated and there is the presence of cilia, which moves the mucus up the airway to be swallowed. This is the lung specimen of a person with bronchiectasis, showing dilated airways with thickened airway wall. As the disease progresses, there may be even cystic dilatation of the airways, like in this case. This is the chest X-ray of a person with bronchitis showing dilated airways, some cyst-like, with fluid filling some of the cyst. These are fluid levels. Now we shall talk about the management of cough and phlegm. The management of cough and phlegm includes airway clearance techniques, ACT, hydration and nutrition, physical exercise, antibiotics when necessary, cough medication, the role of vaccination, regular follow-up with a doctor, and surgery in selected cases. Now we shall discuss air clearance techniques used in chest physical therapy, which includes the active cycle of breathing technique, ACT, Autogenic Drainage, and Postural Drainage, and some of the aids used like PEP devices, positive expiratory pressure devices, Vibratory Pep Devices like the Flutter, Acapella, and Aeropica, and also the high-frequency oscillators like the Best. Active cycle of breathing technique, ACBT. There are three phases in ACBT. Number one is a breathing control, followed by thoracic expansion exercises and forced expiratory technique. Breathing control is gentle breathing using the diaphragm. It is also called diaphragmatic breathing. It allows rest. You can experience diaphragmatic breathing by placing your hand over your belly. As you breathe in, your hand moves out. And when you breathe out, your hand moves in. This is because of the contraction of the diaphragm as when we breathe in. When the diaphragm contracts, it pushes the belly content outwards, and that's why your hand is lifted outwards. Thoracic expansion exercises. These exercises are able to open collateral air circulation and mobilize secretion. Here in this diagram, you see a channel being obstructed with thick phlegm. As you perform thoracic expansion exercise, you will find that air is being moved through this patent channel across the pores of Kohn and also to the channels of Lambert and Martin, whereby the air is able to expel or mobilize the phlegm up and outwards. You can experience thoracic expansion exercises by placing your hand over the area which you want to do the exercise. You inspire deeply, followed by relaxed expiration, and you apply pressure over the area that you're breathing on. Forced expiratory technique, also known as the huff, moves secretions up airways. Breathe out forcibly with open glottis from mid-lung volume to low lung volume. Here you can see a person performing the huff. It will be like taking a deep breath to mid-lung volume and then with open glottis, huff the air out. You can see the movement of the tissue paper. One can expel thick phlegm with controlled cough. Here, the cough is gentle with open glottis. It will sound something like this. important to practice is open glottis coughing. This is a diagram showing the glottis. Autogenic drainage can be self-administered. All it needs is some training. Autogenic drainage has three phases. Phase 1, breathing at low lung volumes. Phase 2, breathing at mid lung volumes. And phase 3, breathing at high lung volumes. Now we shall practice breathing. Breathe quietly now. Breathe in, breathe out, breathe in, breathe out. That is about 500 mils in, 500 mils out, and that is our tidal volume. Now breathe completely out to residual volume. That is the volume of air remaining in our lungs. We would have expelled our expiratory reserve volume, which is about 1.5 liters. Now breathe quietly again. Breathing in tidal volume, about 500 mils. Now take a deep breath in. Fully. That we will have breathed in our inspiratory reserve volume, which is about 2.5 liters. Now go back to quiet breathing. Okay, so now we shall practice one cycle of autogenic drainage. Breathe quietly now. Expel all your air to residual volume. Take a deep breath now. A full deep breath. And breathe out all the air again to residual volume. And breathe now at low lung volume. About 5 times. Breathe deeper now at mid lung volumes. At higher lung volumes now. By doing this, we are actually moving the secretions from the lower parts of the lung up the upper airways to be expelled with a gentle cough. Alright, this is all about autogenic drainage. We shall discuss postural drainage now. Postural drainage requires gravity to help drain the secretions, and body positioning is also very important so that the best position is selected to drain the affected area. When a person is breathless, he may be allowed to sit upright. Percussion of the chest loosens the secretions from the airway walls. Compression helps mobilize the secretion faster. Huffing and controlled cough will bring out the phlegm. The lungs have many lobes. On the right side, there's the right upper lobe, middle lobe, and the lower lobe. The left side has the left upper lobe together with the lingular and the left lower lobe. As you can see from this diagram, there are also many pulmonary segments attached to each lobe. They can be in the front, the back, up or down. So body positioning is very important to affect drainage of the diseased lung lobe and pulmonary segment. Postural drainage requires a person to be properly positioned to drain the affected area of the lung. Like in this first picture, where the person has the right lower lobe lateral basal segment affected, which is around this part of the lung, you find that this is the best position to allow drainage of the affected pulmonary segment. Different areas of the lung requires different position to be drained properly. While performing postural drainage, the assistant can use percussion aids. Pump cups are percussion aids. They are used by the assistant to percuss on the patient's chest, lessening the pain on the person's chest and also the pain on the assistant's hands. Here is a mechanical vibrator. When used, it produces vibration which is similar to the assistant's manual percussion. When there is a chest infection, we need to use antibiotics for bacterial infection. When can we use antibiotics? When there is a change in sputum color, a change in sputum volume, which is more than the usual, when the person is feeling unwell, having shortness of breath, having fever or chills, or when the person has coughed out blood. Cough medicine can be for productive cough or non-productive cough. Today we are talking about productive cough, where the cough produces a lot of sputum. The medicine can include pharyngeal demulcent or expectorant. Pharyngeal demulcent helps soothe the throat and reduce inflammation. They can be in the form of lozenges or cough drops containing honey, licorice or glycerin. Expectorants can be divided into mucokinetics and mucolytics. Mucokinetics help increase bronchial secretion, increase the volume of bronchial secretions, and also help the proper functioning of the cilia. An example would be guaifenesin. Mucolytics are used to reduce the viscosity of the sputum or phlegm. They can be bromhexin, ambroxol, N-acetylcysteine, carbocysteine. Cough medicine can be used for non-productive cough. Today, we are not talking about non-productive coughs. So antitussives containing opioids, non-opioids, and antihistamines are not to be used in productive coughs. Physical exercise is also very important for improving general well-being. Physical exercises should be performed in addition to the chest physiotherapy or chest physical therapy. Hydration is very important. It means drinking enough water to ensure that the sputum and phlegm remains fluid. That is, to reduce the viscosity of the sputum and phlegm. Balanced meals are also very important, containing protein, carbohydrate, lipids, mineral, and vitamins. Vaccination for the following are encouraged: against pneumococcus, against influenza, and against COVID. High-frequency chest wall oscillation can also be employed. In this picture, it shows the vest. Here you have a pump, an air pump, which rapidly inflates and deflates as much as 20 times per second. And this creates oscillation in the chest, loosening up the phlegm in the airways and expelling them. Shown here are two gadgets which are used to expel or bring out phlegm from the airways. Here we see the threshold PEP, and here the TheraPEP. These are positive expiratory pressure devices. When blown through the mouthpiece through a narrowed orifice, they can help mobilize secretions from the airways. Shown here are vibratory PEP devices, pretty similar to the PEP devices shown earlier. However, these devices contain a piece of equipment inside which helps vibrate the airways. So when a person blows through this flutter, there's a steel ball that vibrates. Oscillation is transmitted to the airways of the person, and this helps loosen the secretion and helps mobilize the secretions as well. This is the a cappella device together with a nebulizer head. In the nebulizer head, one can add bronchodilators to help open up the airways so that the person breathes better during physiotherapy. We can also add hypertonic saline or sodium bicarbonate to make the phlegm more fluid so that it can be expectorated easier. Antibiotics can also be added for chest infection. In summary, one has to establish the correct diagnosis for the problem of chronic cough and phlegm. Physiotherapy can be self-administered. Please learn the correct methods. And the treatment has to be regular. And when necessary, seek medical advice. Thank you very much for hearing out this whole presentation. Hope the advice given is of use to you. Thank you. God bless.